Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists. Whoop whoop, listeners, episode 72 with a tale of two hygienists. This is Michelle, and I've started drinking wine.
Nice. And this is Andrew, and I am not. And no Red Bull either, because it's late.
Does it affect you late?
I think so. I think that a Red Bull still gives me wings, as they say. And I was on the airplane for about almost 8 hours today, and I'm so tired. I just got back from Smiles at Sea, which was... Can I say, by the way, Michelle?
I want to hear all about this.
Well, we don't really have time to...
I missed a good one?
You did. We don't have time to really go into it.
Dang.
But I will tell you what. Elijah's got his crap together. The last one was pretty good too,
good
right?
Job,
but
Elijah.
He is getting much, much better. There was...
Practice makes perfect.
I think so. There was over 300 people there this time. And it was quite the zoo. And it was a well-organized zoo. And so I'm pretty happy about that. You know, one thing that they did
and this one was different, right? Because we were on it for 4 days, right?
Right. And so this one was a little bit different because it was only 3 days, and the scheduling of the classes was different. So we had classes each of the mornings. So it was 7 o'clock 7:30 to about 11 o'clock or 11:30. And then we got off the boat, went and did our thing, came back, and then in the evening it was like the social time. So there was the speed date your vendors. We did that again, and then and it was really nice because all the people actually interacted with the vendors. And then it was there was a couple of different events. We had there was a dance party and karaoke, and there was
fun.
A crap ton of prizes given away. There were good prizes too. I won another prize, by the way, that we are going to be giving.
Something.
I know, but we are going to be giving this away to our listeners. It is a VIP registration for the September Smiles at Sea. So I won that again. So we'll be giving that away probably the next couple months because I think that would give someone.
So who can suck up to Andrew the best?
I think it'll be actually just like, hey, tell us why you want to go, and you'll be entered into a drawing. And
cool.
And that's what we should do with it.
Well, that's nice.
But yeah,
great. So good one.
Yeah.
I'm
so sorry for my
to hear more about
lack of enthusiasm. I'm just super, super tired. But it was good. It was really, really good. And Miami, I had some Cuban food. Oh, it was the best. It was so delicious.
Welcome to Miami. I do love Miami, but Miami's Cuban food is much different than Cuba's Cuban food.
Oh, I'm sure. It's got to be Americanized somehow a little bit.
But in a good way. Like Cuba doesn't have imports of spices and stuff, so
yeah.
It's very bland compared to like the Miami version of Cuban food.
Well, I liked it. It was delicious, and I would go there again just for the food.
Well, good. Come back to the East Coast. I liked being on the same time zone.
I told you, I think I really like being on the East Coast as well, like the time zone at least. So maybe I'll just rearrange my life so that I'm always on East Coast time, even though I'm living on the West Coast. I think that's what I'll do.
I think that would be very dumb, but go ahead and try.
I'm not going to do that. But anyways, so
4 a.m., wake up, get things done.
Yeah.
Go to bed, 7 o'clock, 6 o'clock.
Sounds good to me. Right when I get off of work, I go back to bed.
Right? So I'm excited about today's interview because I've known Dr. Hyland for a while. I actually first heard Dr. Hyland and his daughter Carrie on Howard Ferran's podcast. And this was kind of a weird, strange thing that happened. So I heard it on the way out to the AAP meeting, so the American Academy of Periodontology. It was in San Diego last year. And I'm listening to it on the flight. And then I was exhibiting in the room, I had sponsored Dr. Fromm and Dr. Chris Salerno, who has already been on the podcast, for one of their hands-on meetings. So only so many people can register. And there's only 3 exhibitors in the room with us. And one of them was Dr. Hyland. And I had no idea.
Really?
So I had emailed him previously, but I didn't. It was almost like I was listening to the podcast without really knowing who I was listening to. Because I'm so terrible with names and keeping track of it. So,
amen.
I just had listened to the concept of what he was talking about. Was kind of interested in it, and then so he and I started talking. We kind of walked out because it was cold in the room and chit-chatted more. And I was like, "You should be on the podcast." And then I listened to it again. I was like, "Oh, I'm so stupid." It's him. I was talking to him. So this is also why you should always be on your best behavior, because you never know.
That's right.
But it's great. You'll really enjoy it. He is with Oravital. He is a practicing dentist in Canada, but works quite a lot with the American Academy of Oral Systemic Health, and has his own little thing going called Oravital, which has great webinars, FYI. So you should sign up. Patty DeGangi just had one, and prior to that, Debbie Z was on one. So some of our favorites are on there doing really great webinars. So check that out.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. All right, listeners. Again, we are at Midwinter, still here. It's going to be like a gazillion weeks into
interview number 5 or something like that.
No, I think it's even more than that.
20.
Something like that. But we, again, are live, and we're on almost our last interview of the day, but this is one I'm actually the most interested in. So this is Dr. James Hyland, or you go by Jim.
Jim's just fine.
Good.
Thank you for having me today.
You're
I'm looking
welcome.
forward to perhaps sharing a new message that can give a lot of hope to hygiene, in particular for a change in the way we're going to be practicing dentistry, and to getting our patients healthy in a way we've never been able to do before, predictably, and as I'll tell you later, actually guaranteed.
That we like to hear that word.
Yeah, so that's something that you just launched, right? Results, guaranteed results?
We did. A study was done on 649 patients. Interestingly enough, none of the patients had scaling done. These were patients that had breath odor treatment, and the same bacteria that cause breath odor caused gum disease. And what we found is that when we started using the antibiotic mouthwash, they called us up and they said, the breath odor's gone. That didn't happen with all the other treatments, oral antibiotics, chlorhexidine, any of the over-the-counter rinses. And they said at the same time, by the way, our gums stopped bleeding. So the background of the company was one that was treat breath odor, and 95% of breath odors are coming from the oral cavity. They're not coming from the esophagus. They're not coming from the lungs. They're not coming from the nasal passages. And even healthy mouths have gum disease. And the odors are coming usually from the back of the tongue and the throat, where you can't see, test, and they can't clean, so the odors persist in spite of their best efforts.
Well, I think that might be an attention grabber, because I want to circle back. So that if you're not interested in after that little thing,
that
then
teaser. That was good.
It was a nice little thing there. Let's talk about, so you were a practicing dentist.
Yes, I was. And still am.
Still, and in Canada, right?
Toronto, Canada.
Yes. And your daughter's a hygienist.
Yeah. That's right. Go Leafs, go.
Love it.
And your daughter's a hygienist.
She was. What actually happened is that somebody who was a hygiene educator for about 30 years had been treating breath odor. And I was the first dentist that she visited. And she told me she wanted to teach me her system. And she told me that the same bacteria that cause breath odor cause gum disease. And I said, that's interesting. And she said, I have a 90% success rate in treating breath odor. And I said, stop for a second. If the same bacteria that cause gum disease cause breath odor, what happens to the gums? And she said, well, they get really healthy quickly. I said, that's really what I'd like to focus on. And you mentioned my daughter, Carrie, so I turned to my daughter and I said, Carrie, I want you to integrate a perio program that involves this into the practice and change it from a breath program to a perio. So I enabled her to do it, and things have evolved to where we are now, where we focus more on periodontal care, but do teach practices how to take care of patients with breath odor as well.
And so what is this company?
That's called Oravital. It's a company that specializes in the diagnosis of disease, both in terms of objective tests that we ask hygienists to do that are a little different than you might do at the moment, but probably what you were taught to do in school. Salivary testing that can be done with DNA or gram stain for breath. And then the use of antibiotic and antimicrobial mouthwashes as a finishing treatment after all your care to kill and control the bacteria that cause the disease, and then you create an environment that they can clean and maintain, and they get sustainable health.
Okay, so let's break that down just a little bit, especially for our students, new grads, and people who have just never even heard the idea of salivary testing. What actually is salivary testing?
There are 3 ways that you can do it on the market at the moment. One company uses paper points, and I think that's the most accurate test. It's a subgingival test. So you simply take a paper point in about 5 locations, put it under the gum for 5 to 10 seconds, and you pull it out and put it in a vial, and you send it to the company, and they will do a DNA analysis.
Okay.
Another method would be to spit some saliva into a small container, and the saliva is sent. Mm-hmm. The saliva produces, I'm concerned about variable results. And the reason is if you have an alcoholic mouthwash, if you drink a lot, eat a lot, you're going to have a variation in the bacteria in your mouth. Mm-hmm. And so it's not a standardized type of test. So the results vary a lot. Mm-hmm. Both of them, as the standard of care, will analyze the bacteria that are there, and they'll recommend that you use an antibiotic that's targeted to the bacteria that they find, but they're going to recommend oral antibiotics. The difference for us is that we recognize from what we were talking about breath odor that we have to sample the back of the tongue and the throat. So what we do is we use paper points under the gum, and we use a small pad that just wipes to the back of the tongue behind the circumvalent papilla, and about 1/2 a second you pull it forward to the tip of the tongue. So you're picking up throat and tongue biofilm, going to dip it in the saliva, and uniquely, you're going to rub it along the lingual surfaces of the upper and lower teeth to pick up the supragingival. So now you're getting subgingival, supragingival, saliva, and whole mouth biofilm. In other words, you get a total picture of the mouth.
Right.
I love that total picture.
And on top of that, when you measure the bacteria, we're going to tell you about periopathogens, which the others do, but we'll tell you about yeast and about strep mutans as well. Mm-hmm. So you're actually getting a whole mouth profile that gives you, I think, a better picture of what's happening. Yeast is something I mentioned that most people wouldn't think about testing for. Can I give you a little history behind that?
Please.
Okay.
Yes.
So we originally used to do gram staining, where we would take a mirror, just an ordinary intraoral mouth mirror, put it at the back of the tongue, put it on a slide. Wipe it, put it in the front of the tongue, put it in a slide, and then floss or use picks between the teeth and pick another third area and put it in a slide. And we would do like a phase contrast microscopy look with gram stain. What we found was that the back of the tongue had complex biofilms, and this is very important for everyone, that matched periodontal pathogens and periodontal pockets. So in other words, whether you were looking at the back of the tongue or subgingivally, same type of bacteria. Mm-hmm. So our original treatments were oral antibiotics, mouthwashes of various sorts. We never could change that bacterial profile. The very first time we used an antibiotic mouthwash, the patient called up 3 days later and said, my breath odor is gone and my gums stopped bleeding. And when we sampled the biofilm at the back of the tongue and throat, it was a normal biofilm. So what we've done for the first time was control a whole mouth pathogenic biofilm, and the particles of antibiotic will go 6 millimeters into tissues. So it will go subgingival, and being particulate, it's like a flower. It's very fine. Mm-hmm. It's a sustained release. So you get a high concentration, and you get sustained concentration, and you get no systemic effects. So this concept then of whole mouth testing is important, and treating biofilms throughout the mouth, because if you don't treat those ones at the back, you do your scaling and root planing respectfully, and they reinfect themselves. Mm-hmm. And so although you move the bacteria around with scaling, you don't kill them, and then the bacteria reorganizes and the process starts again. So we're offering a different way of treating the disease that produces more permanent results.
Especially since if you did something like a Reston subgingival, you're not really doing anything for the back of the throat. And if
you aren't. And so the challenge then is you have to treat the entire oral cavity with a rinse. We have a product like a Reston, Atrodox. It's a cream, and it contains the metronidazole and the nystatin as well. and that the patient would apply locally. We originally had it.
The patient would apply?
Patient applies it. You can inject it with an acid-etched syringe into deeper pockets, but originally it was used because patients would have persistent odors between their teeth after treatment. So we teach them to floss those areas or use picks in those areas to kill the bacteria to control odors. Well, the gum disease went away. And now we use it around implants with mucositis, periimplantitis, and we use it for localized pockets for the patients to treat at home as well. And since they're treating their own disease, they do it right, and they monitor the results, and they're involved in their care, and that's what you want, because it's not the procedures we do that get people healthy. I actually tell you have to do 3 things to get people healthy. 1, you have to inspire and motivate them to do what's in their best interest. Now, that's simply said, but not easy. I can talk about it in a few minutes. Number 2, you have to teach them techniques that work. And unfortunately, it's not brush your teeth, floss, and have your teeth cleaned. If that was working, they wouldn't have the bleeding. And number 3, we have to create an environment they can clean and maintain. So that means if they got broken teeth, you fix it. Pockets, you fix them. Gaps between the teeth packing food, you take care of that. A lot of scale and tartar, you should remove it. But you have to create an environment they can maintain. And when those 3 things come together, you have sustained health for a lifetime.
So with the microbiota subgingival being so complex with pathogens, yeast, and viruses,
yes,
is the antibiotic rinse also having the antifungal?
Yes, it does. So I got away from what I was saying. When we were sampling the back of the tongue and throat and subgingivally, we found routinely subclinical yeast infections. Mm-hmm. Now, most readers may not be aware this is a pearl. If you have early childhood decay, you have a yeast infection. And the yeast infection acts like a spider web over the tooth. And into that spider web goes the strep mutans and the lactobacillus in a protected environment where they're far more virulent and they can produce higher acid production and greater acidity, and that's what gives the rapid decay. So you must have a yeast infection for early childhood decay. You also must have a yeast infection for root decay, geriatric. Think of your geriatric patients, the dry mouths and things like that. What we also noticed was subgingivally, we had a lot of yeast. So you know what a yeast infection looks like if you touch the tissue. You've got that red inflamed tissue. Picture that if you could peel the gum back and look at a minor yeast infection in the gum, how easy it is for periopathogens to get into that.
Of course,
and so if you don't control that, you also will not be able to control the perio as much. Interestingly enough is that nystatin weakens the cell walls of bacteria. So when you use it to kill the fungi, you weaken the cell walls of the bacteria, so your antibiotic is more effective. So it's like a 2-for-1 punch. It's an area no one's thought of looking at before. Does that make sense, Michelle?
Absolutely.
Makes a lot of sense.
So if they're having such a yeast infection in their mouth, which is the beginning of digestion, would this also be linked to gut health?
Well, what's
a way?
in the mouth, it starts there, your yeast infection, and goes into your gut. Mm-hmm. So you need to control what's here, or again, they're seeding themselves.
Right.
So we're big proponents when you're taking an antibiotic mouthwash and when you use the antimicrobials, that at the same time you're going to use a probiotic. Okay. Now, for the oral environment, we want a probiotic that's going to dissolve in the mouth. They will swallow that with saliva, but we don't want a pill that's swallowed because we're trying to change the environment here, and then those bacteria can be swallowed and get into the gut.
Is that one that Perioscience has?
There are a number.
Yeah.
We recommend several. I won't mention specific brands. We don't make ones ourselves, but probiotics are important. It's about creating wellness and a stable ecosystem that is free from enough pathogens that the body can maintain health.
Can I circle back to, you mentioned, the 1, 2, and 3, inspire and motivate, teach techniques at work, and then create environments that they can clean and maintain. Can you speak a little bit more to each of those steps?
Sure. Yeah. When you're speaking with a patient, if you use some of the verbal skills I'm going to mention now, it will transform your relationship with patients. One of my greatest mentors, Walter Haley, said, ask, don't tell. Mm-hmm. So don't lecture them. Ask them questions. Make it interactive. So if I say to you, Michelle, if you could imagine yourself as a patient, if you have gum disease, would it be more important that you brush your gums or your teeth to prevent gum disease? And I'm seeing you smiling, but that's what patients do.
So simple,
they smile. It is so simple.
Yeah.
But if I tell you to clean the garage and the dirt's in the living room, the garage is still dirty. So when people clean their teeth, they do not clean their gums. But if you clean the gums, you always clean the teeth. Now we're going to cause recession. You never cause recession with a circular technique of brushing, and especially if you hold the patient's hand and show them how to brush their entire mouth. Hold the patient's hand and show them how to brush their entire mouth.
I never really understood the fuss over the recession. What's the other result? Periodontal disease? Like you're just going to leave the bacteria there?
Exactly. So you have to teach that.
Come on.
Okay. Second thing is that we teach people to floss their teeth. I'm not an advocate of flossing. And if I can take a moment to explain why. Mm-hmm. So there are 3 times that I teach flossing, and they're for cleaning convex surfaces. So that's cleaning a pontic, cleaning an implant, and cleaning between the teeth if nothing else will fit without causing trauma, which was Capel's study in 2015 looking at 1,500 studies on flossing. And what he found was flossing can only be recommended in periodontal healthy mouths, and then only if nothing else fits between the teeth, listen to this, without causing trauma. So hygienists and dentists have to get over it. Stop teaching flossing as the primary method. Now imagine this question.
Hallelujah, preaching.
Okay. Andrew, if I could show you a method of cleaning between your teeth that didn't involve flossing, how would you feel about that?
Please, please, please.
Please. Now I've opened up a different conversation to hygiene now. In fact, guys are going to raise up both hands and say, please.
Yeah.
And so I tell them that we can use picks to clean between their teeth. And later on, I'll talk about the bleeding index. Mm-hmm. And then I say to patients, does it make sense that, do you understand that cleaning scale and tartar does not control the disease? And we tell you to brush your teeth, floss your teeth, and have your teeth cleaned. Because I said, imagine that you're using sterile instruments in infected sites, and we use the same instruments in healthy sites. And Andrew, just like you're looking, your face is saying, the patients are looking at me and saying, well, that makes no sense at all. Yeah. And I'll say, well, what I'd like to do is to disinfect your mouth before I scale if I see bleeding. I said, what does your physician do before you get an injection? And they go, well, they wipe it with some alcohol. What do they do before you do surgery? Well, they disinfect. I said, how would you feel if they didn't do that? We said, that's not right. So we don't do that in dentistry. And then finally, we minimize disease. And so I ask a patient, I say, Michelle, how would you feel if you went to see your physician and you had blood in your urine and the physician says, Michelle, come back in 6 months, it's a little bleeding. The reaction some patient faces is, no, that's not right. I need to find a new physician.
Yeah.
Well, now I have them in the sweet spot, and I say to them, so if I find bleeding in your mouth, are we going to watch it, or are we going to do something about it? And the patient gets trapped with their own words, and they've agreed to care that involves stopping the bleeding. Your challenge now is you're going to tell them to brush their teeth, floss, and have their teeth cleaned, because up to now it hasn't worked. So we want to talk about change. And that verbal discussion with the patient sets up the change. And now you get into how do you motivate them? Well, what's in it for me is what they want to know. And if you can't show that, it doesn't happen. So I use the soft pick or Stimudent or the Tepe in particular, and brushes rarely. I use them more for large spaces. I want firm pressure between the teeth, and I'll rub that along their lip, their tongue, the surface of the labial gingiva, and I'll say, does it hurt or bleed? They all say no. I'll say that's because it's healthy. It doesn't do that. And they have a mirror, and I watch as I do it between their teeth, and they're pulling back because it hurts a bit, and I'll say, your gums are inflamed. I said, think of them as a blister. I said, it's blistered. And then I'll say to them, can you see the bleeding? And they're going, yeah. And after they've done 3 or 4 spots, many of your patients literally will have blood pouring into their sulcus. And that's what happens to hygiene when they start scaling. It starts bleeding. You have an argument with the patient about they have gum disease. They say, no, you shoved a sharp instrument in my mouth.
You're poking me with that sharp instrument. Of course I'm bleeding.
And I like the other hygienist. She was so gentle. You're killing me here. But they can't argue with the fact they see the bleeding. And now I ask them with the bleeding, do they have gum disease? I ask a question. They say, yes. And you have to ask this question.
So you're
Andrew,
asking them to diagnose
I'm asking them
themselves.
to diagnose their disease. They say, I have gum disease. That's different than you have gum disease. And then I ask them, Andrew, are they kissable? And they look at me, and the next question is, how do I stop the bleeding? But at this point, I still want to go for the heart. I want to go for their emotion. Remember, we're inspiring and motivating. I'll say to them, do you know when you kiss somebody, you spread blood? And I'm making a face when I say that. And they go, oh, that doesn't sound good. I said, in fact, do you know how you catch gum disease? They go, no. I say, it's spread through kissing through saliva. At that point, all they want to do is get healthy.
Yeah.
Now, if they have heart disease, and I've linked it to their medical condition, and then they see bleeding and kissable, that's how you get to a patient's heart.
Yeah, because we are learning that it is a transmissible disease.
Yes.
And the bacteria. And what Dr. Larkin said that a dog, they even connected to someone's dog was giving them.
A Swedish study found that. Exactly. They reinfect from a partner or from animals. Exactly, yeah.
Oh, Lord. You are too close to your dog. I love my baby girl, but I'm not getting any oral bacteria from her. I can tell you that. Yeah. Okay, so that was
number one.
Yeah. So number two.
Number two is create an environment where you control the disease. So we have to get pockets that are 4 millimeters less and don't bleed when they're touched. So I'm going to say, dentists have a real hard time with this. They have a hard time what I call pulling the trigger. If a tooth has got a 7 millimeter pocket, it is hopeless. Predictably treatable, hopeless.
I see. Okay.
So you want to have a discussion with the patient. I can try LANA. I can try surgical procedures, but I cannot predictably tell you when we're finished that this will be something you can maintain. The patient says, I want to try it. No problem. But if they can't afford to have that treatment and have it fail, and then they can't afford implants or partials to replace the teeth, you haven't done good care for them. So ask them how they want to be cared for. Do they want predictable treatments?
Yeah.
And this way you don't have problems afterwards. You told me this would fix the problem, and it didn't. Now who's going to pay to replace it? Exactly. So if they have 6 millimeters or less, I generally work with it. At 7 to 9, I'm suggesting they should have implants placed. And when you do that, you rule out a lot of potential for reinfection and failure where you're maintaining sites that you can't get healthy, and so you can't predictably get the patient healthy. If they're 6 millimeters or less, and I start getting them using the papillary bleeding score and using that on a daily basis, on the third day, I tell them I guarantee the bleeding will stop. We need to clean the sulcus. So we teach rubber tipping usually to go between the teeth, but I teach it to clean like under your fingernail. So buccolingual with very firm pressure, especially into furcations and things like that. And the second or third day, amazing things happen. In fact, I tell most of the patients they only have to do their molar teeth because that's where most of the pockets are on them. Yeah. And so you're not trying to get them to over-treat themselves.
The whole mouth, and they're overwhelmed.
They're overwhelmed. Yeah. So in the beginning, I teach brushing and picking. On the next visit, if I see it, I'm not getting the resolution I want, I'll teach a tough brush or a rubber tip. And if they still have pocketing, I'll say to them, the only thing I can try now might be irrigation. And the irrigation I'll use with rinse with something like peroxide or an over-the-counter mouthwash. But I'm doing it progressively based on need, not trying to get them to do everything all at once because they won't do that. And they're buying into the treatment and they understand what they're doing isn't working, so they need to try something else.
Right.
So now, if you've got a lot of bleeding, let's say, you have to decide, how do I treat that? And the treatment isn't go away and see what it's like in a few months. It isn't, I'll check it in 6 months again. So you mentioned the connection. So I remember, for instance, when John Kennedy was shot. I was alive, okay? And I remember it because it was such a significant day. Well, dentistry changed on the 29th of November 2016 when it comes to oral systemic practicing. Because on that day, Dr. Bale and Dunneem published a study that said, for the first time in literature, in the British Medical Journal, gum disease high-risk pathogens cause arthrosclerosis. Causal was used. Now, if you have high blood pressure and see your physician, are they not obligated to treat that high blood pressure and bring it under control? And if they ignore that or tell you to go away with a little high blood pressure, they're going to be in trouble in front of their boards. Dentistry has changed, and you can look at it as an opportunity now or a threat to your practice. The opportunity is you can help patients get healthy, you can influence their systemic health, you can change the way you present care, and now bleeding matters. Or you can ignore it and take the risk that later on you get blamed for not helping them with the disease. So the standard of care coming back to diagnostic testing now is that you should be testing patients that have risk. Who is at risk? Someone who bleeds. That's 75% of your patients. Somebody that has heart disease. Somebody that has diabetes. Someone that has inflammatory autoimmune disorders. You're talking about 85% of your practice now. So all of them need to be offered the testing. Then they can decide if they want to do it or not. But to not offer the test leaves you at risk.
And what a simple way. I mean, really.
Yeah.
You're testing 5 spots and could be able to tell the patient information and receive information that
well, I think
help
a
you
lot of
maintain
times
them.
dentists are worried that, well, it's just going to get the same results for everybody.
Yeah.
But the physicians still test everybody all the time.
Yeah.
They're looking for small risk factors that pertain to that patient.
Right.
So, for instance, if it showed high AA bacteria, the only way that AA bacteria will respond is if you use an antibiotic to kill it. And if you're not doing that, then you can't control that infection. These are the patients that go on to refractory disease as well. And when you look at how important are antibiotics to use in practice, we don't want to overuse them. We don't want to have resistance. But if it's causing heart attacks, if Michelosi's study that shows 93.7% of the patients that have Alzheimer's have oral pathogens, spirochetes in their brains, and the same spirochetes cause Lyme disease and syphilis, and I want to tell you, you'd want an antibiotic if you had Lyme disease or syphilis.
Yeah.
So we've underestimated how pathogenic these bacteria are. And I think the studies are showing it's not the severity of the disease. It's how long you're exposed to the bacteria. So think 24/7, 365 for decades of gingivitis. And you don't know which patients are susceptible or which have the gene that make them more prone to infection and inflammation. So you have to practice, like with gloves universally, you have to universally practice to zero tolerance. And then the patient can accept not. We just can't not practice that way.
And so when they're on an antibiotic regimen, what is what is that regimen?
Well, it's simple. It's 3 times a day for 30 seconds to rinse, gargle, and spit. Swish vigorously. And then we want you using picks between your teeth afterwards to both cleanse that area and to push the particles in more. And then you get it deeper into the pockets as well. They do it for 2 weeks, and then they're going to have killed the gram-negative anaerobes. So you've killed between 13 and 20% of the bacteria in the mouth. Then you're going to get an overgrowth of gram-positive. So you're going to rinse with something like chlorhexidine. Our tests are with chlorhexidine, so I'll speak to that. And then you want to put them on an over-the-counter mouthwash that can be directed at what they're doing. So something that tackles gram-negatives like Closis, like Smart Mouth if they have perio, something that has CDLX in it, like the Crest Pro Health, if they have caries prone. We have rinses like Closis that have xylitol, and ones like Crest Pro Health that have xylitol as well. So if a practice wanted to use something generic that the patient can't buy over the counter and ties them to their practice, they can consider doing that as well.
This is like...
I feel like this is usually going to turn a little bit of head, just because, like, you think about even rinsing and then pushing it through with any sort of
device,
dental
device
or something to really get it to seep down. I mean, it makes perfectly logical sense.
Yeah.
And why aren't we doing it?
Especially now knowing what we know, what you just said about the throat bacteria.
Yeah.
And how just putting something subgingivally after a scaling and root planing is not going to necessarily do much because they are going to just reinfect themselves.
Exactly. I think what you're saying is it almost seems too simple and easy
really
to
does,
work.
yes.
Yeah. And it's one of those cases, don't look the gift horse in the mouth. Okay?
Right.
I ask people to evaluate what they're doing now and how effective what they're doing is. And most people will say, I can't get patients to agree and I can't control the problem. And so we're asking for really a fundamental change in the approach to periodontal care. And this is layered on to what you're doing. So, I mean, for instance, if you're a person that uses lasers, this is fabulous. So you'd use the laser to do decontaminate, or you do your LANAP therapy and you'd use a rinse afterwards. If you're someone that wants to use other systems, like Perio Protect is a system, but I think you understand now the challenge is it doesn't clean the whole mouth. And they have to stay on that tray twice a day forever.
I was going to say patient compliance.
And no one's going to do that.
Yeah.
The compliance isn't there. So it's a simple system, Michelle, and it works well. And it makes sense to patients, which is why they buy into it. So, yeah, it's a compounded rinse. You have to order it from a pharmacy. It gets delivered within 2 days to the office. The patient picks it up. And you're always going to schedule a reevaluation appointment. Now, we talked about objective tests. I visit hundreds of practices, and every practice I go to has their own way of treating perio. But if I'm bonding a restoration, there's one way I do it. And if anyone tries to change my system, I'm not changeable. You have to really prove to me it's better, and it's going to be hard. So all of us can't be right. There can't be hundreds of ways of treating perio.
Right.
We need a standardization. So I mentioned it goes back to what you learned in school. You need to disclose every patient. So why? Well, imagine you have to clean up the kitchen table. But I'm going to put a blindfold on you. How good a job are you going to do? It's going to be difficult.
You're probably going to make it worse.
So how can you be sure the patient has cleaned their mouth well and the biofilm's under control if you can't see whether it's even there or not? And they can't see it. So how can you teach them to brush? You're telling them they have biofilm. They can't see it.
Right.
It's very simple. Number 2, you have to measure pockets. I hate the word probe. It's very alien, isn't it?
Okay. I know. And I even have a hard time.
I know. I hate using that word.
But I still have a hard time not saying it.
I know. It's ingrained in us as far as that goes. So what we ask is you do either a PSR or you do periodontal charting on each visit. So you have to do some sort of sounding recording. And if you're doing perio charting, please record the number of bleeding points. We want to know the score after a game. You have to know the score. And so the last thing you want to do is that papillary bleeding score we talked about. So then you use those 4 things to tell you, do you have health or disease? Have I reached an end point where the patient is stable, or do I still need to do treatment? Are they diseased that I need to treat because I've just met them? And then when I've treated them, has my therapy worked? Okay? So what your goals are, number 1, no biofilm on disclosing. Now think about that. If there's no biofilm on disclosing, they're going to have little gingival disease buccally and lingually. Number 2, 0 on the papillary bleeding scores. So when they go between their teeth with a tepe or soft pick, there is no bleeding. Again, fingernails don't bleed when you clean them.
Right.
Use scalers to clean your fingernails. They don't bleed. The gum shouldn't either. Number 3, the pockets have to be 4 millimeters or less. Now, we know there are exceptions. Distal of molars, distal lingual, thick fibrotic tissue that doesn't bleed. There, you understand there are areas that you can leave alone there. And the 4th, I've lost my train. So anyway, but basically you want to have pockets less than 4, no visible biofilm, 0 papillary bleeding score, and bleeding on probing. This is going to sound funny. I'll accept under 10. Now, why not 0?
Because you're a realist.
I'm a realist. Yeah. I mean, 360 degrees around 24, 28 teeth.
Yeah.
4 millimeters deep with the tongue and gagging and fillings and crowns. It's not realistic.
Right.
So I am trying to get people into the 5 and 6 range, and we actually have a little gong in our practice. And when they get there, they ring the gong in the hygiene.
That's fun.
And everyone says, who's ringing the gong? Why? And we get to tell the story. And it leads to people talking about it. And they get excited about what's happening. And when they get healthy, get excited.
Yeah.
The patients want to know they've improved. You're lecturing them all the time. Tell them how well they're doing.
I like it.
I like that a lot.
So do you think periodontal disease is curable?
Well, is a bladder infection curable? Sure. Is a lung infection curable? Yes. Can you get it again? Yes. So that's a word that is kind of fighting for some people.
Yeah.
So, I'll say absolutely controllable for 90% of patients. But if you got 6 millimeter pockets when you're finished, it's not controllable or curable. So either you accept those or you get rid of the pockets, however you have to do it. And then if the patient will maintain them, yes, it is curable, I would say. I'm stepping out.
Nothing. Michelle and I have a little bit of a
debate.
I got caught in this one.
Unwittingly.
I set you up, and I'm sorry.
She was trying to set you up, but I don't think it was the answer she was hoping for.
No. It's I think it's still episodic a lot of times. It's a host response.
In the
and
absence,
if the patient controls,
it's all up to the patient.
Yes.
Yes.
But, mother-in-law comes in town, it's the holidays and whatever, and you don't do all the things you're supposed to do, you can get, it will
come back. So I tell patients in 3 days they will get healthy, and in 3 days it'll come back if they stop doing what they're doing. A little verbal skill: bacteria don't take vacations.
Yeah.
I like that.
Yeah, so true.
And if you're going to take one and they don't, then we start all over again.
Yeah.
Right.
Okay.
Love it.
And the other thing, when you have this type of conversation with the patient in the beginning, say to them, "Has anyone told you this before?" And they're going to say no. And you say, "You know what? It's new stuff I learned. I can't believe it. It's just so simple, but it works. It's not your fault. Let's start from scratch."
I love that.
You know,
not your fault.
Be their friend. And try and find ways of not blaming them with what's happening. So when you disclose, for instance, we know what the people that are right-handed, they can't clean the lower right side in the cuspid. And I say, "Oh, you got the windshield wiper effect." They go, "What's that?" I said, "You ever watch the windshield wipers going back and
like
forth?
That
There's
one little
area, and it never gets cleaned." And I go, "Look at this." I'm waving my hand back and forth, and they're going, "Yeah." And then I say, "Look at the disclosing." And I say, "Now just pull your hand over." And they go, "Oh, that was simple. You've eliminated 3 or 4 bleeding points for the next time they come in."
I love it.
So you'd nickel and dime it down to 0 a little bit at a time. Does that make sense?
Absolutely.
Yeah, it does.
Absolutely. Well, we did a really poor job in dentistry of educating our patients for many years. We just said brush and floss. We never told anybody, showed
We did our
them.
best. We did what we were taught.
And we didn't,
but it doesn't
follow
work
through the patient. It's like handing somebody chopsticks and you're like, "Well, here, feed yourself." Like, not everybody can do that. So you do have to baby step them and help them understand that they're not wrong. Help them understand that they're not wrong because they were doing what their mom showed them when they were kids, but that maybe they have something that's, they are missing, or they're left-handed.
Yes.
And people were telling them they were doing something a righty should have been
Teach
doing.
them how a right-handed would do it.
Yeah.
That's right.
So
That's
just
right.
kind of baby stepping them into it.
So what I find is this actually now gives you a chance to have a lot more fun with your patients. So I'm really a doctor hygienist. Okay? I have disclosing in every treatment room. I have, interproximal aids in every treatment room. I have toothbrushes in every treatment room. And if I see inflammation, I say to the patient, this is another verbal skill. I'll say to them, and I'll put my hands over my eyes. If you can picture me now with my hands over my eyes, and I'll go, "Do you want me to ignore what I see, or can I talk to you about it?" What does everybody say? Yes. I'll say,
about it.
"I see some inflammation, and I know that, I'm fixing some cavities, and that's only going to lead to more cavities. And, actually, you become a dividend-paying stock for me if I ignore this problem, or if you ignore the problem. Can I show you how to take care of it better?" And they go, "Yes." And then when I'm doing my restorative dentistry, you know what? I'm not putting in pink fillings. There's no bleeding.
Yeah.
I put in crowns and veneers. I'm not getting shrinkage of the tissue. They're not blaming me for receding margins. And if I teach them how to clean their gums well, interesting enough, they don't get decay. So my dentistry lasts longer.
Yeah.
So your patients are your friends if you're on their side, because all of this is about getting them healthy, not about doing procedures to make them healthy.
What's interesting, doctors, is a lot of times, and Michelle and I disagree about this part too. It's just kind of funny because we disagree about a lot of things.
Yeah, a lot of things.
But one of the things is I don't really care for the doctors to go behind my work. As a hygienist, I want them to be trusted. I want them to know that I am doing my very best for the patients. And normally I don't like doctors going in after my work. But I'll say this. After listening to what you're saying, I would love it to work with you to get our patients healthy. And I really wish that this message would go not just to our hygiene audience, but also to the dentists out there, because it really is a message of health in a grander scale, I think.
Well, and I think the reason that we disagree is because I do feel that if I came into you, Dr. Hyland, and said, or in front of the patient, said, "We're seeing some 6mm pockets or 6mm measurements in whatever," I actually want you to pick up that probe and check
Exactly.
I want you to be a co-therapist with me, and that's where we disagree. But if you were going behind me just because you didn't think I did a good job, that's a completely different story.
And I think that's what it was for me.
I think, too, at the end of the day, I'm not perfect, and I have missed fractures. Like, I've been hitting, maybe I was chit-chatting, and they spoke when I missed the mesiolingual of whatever, number 30.
Yeah.
And then you came behind me and found that, and we're like, now we got a 9mm pocket. And I'm like, oh, what? The what?
Yeah.
We got a what?
Yikes. What I find is when I see 5 and 6mm pockets, I like to go back and remeasure myself. And the reason is I actually have 4 hygienists that work full-time with me, so I've got a very busy practice. Each one does things a little differently. Mm-hmm. So I have to be the standard bearer. So not in the sense of checking or catching them doing things wrong, but to confirm that things are the way I would assess what needs to be done. And it usually is not much different, but if it is different, I try and find out why I got a different reading from you. Mm-hmm. And it's often that we're holding the ruler at a different angle.
Yeah.
I tried not to say probe there. We're holding a different angle.
Sure.
And that's really what you're dealing with. And the different angle is going to make a big difference. But so what I have to get dentists to learn to do is to say yes. I found that there's a lot of bleeding. Yes. Mm-hmm. We had pockets 5 to 6mm. Yes. I've recommended that they do whatever you recommend. Yes, that's a really good idea. And I'm just nodding my head. Do you have any questions for the patient? No. Let's follow through with the treatment that's being recommended. That's what dentists have to learn how to do. But the hygienist has to be empowered, but also has the responsibility to present things.
Yeah.
Like it's this business of co-presenting. Mm-hmm. Where you repeat in front of the patient, and then I get to respond, and the patient's listening, and we're saying the same things over again, but it's an over here. That's critical to success in treatment.
Right.
So it's not just a rinse that gets people healthy. Mm-hmm. It's that whole experience they have.
Absolutely.
Yeah.
I totally agree. And I mean, even then you're looking at, you're hearing the patient, and the patient says they just heard me. So Mary had her mom in town, and she kind of fell off the wagon. We're seeing some inflammation. She also noticed, she's getting some sensitivity in her teeth, and her TMJ has been hurting her. I suspect that maybe she was doing a little clenching, a little grinding. She's getting a little sensitivity, things like that. I think it validates them. And I will say, even as a patient, when I go to a physician, I hate telling the nurse one thing and then having to tell it again
to the doctor.
It is so annoying.
Yes.
So if the nurse came in there and was like, so Michelle and I just had this conversation, this is what is happening, I'm like, yeah, what she said. Like, I don't have to say it again. And I think it kind of is a validating experience for the patient.
That type of handoff is very, very important as far as that goes.
I agree, totally.
So, Doctor, we have a question from one of our listeners. His name is Mike from Olympia, Washington. He asks, how do you handle it when there are significant differences in pocket measurements? So as you're going through and it sounded like you're trying to, while you're the standard bearer, you're also trying to help kind of get everyone to your standard.
Yes.
By not checking up on, I don't mean to say checking up on them, but checking up on them. Yeah. So what happens when you find those differences?
You've got the first of all, I want to do no harm for the patient. Mm-hmm. And I don't want to create a crisis of confidence or a feeling from the patient that I'm telling the person that's done the measuring they did it wrong. Mm-hmm. So I'll say, can you show me how you measured this? Okay? And then I'll say, well, when I measure at this angle, I'm getting this. So I think what's happening is one of us is turning the ruler, the measure, the probe, the wrong way, and I'd prefer that we do it this way so we get a standardization. Because my challenge is I have to base my therapy on that treatment. Right. And if, Mike, you were to measure something 2 millimeters deeper than I could measure it, I might be talking about doing a surgical procedure to correct that problem when surgery is not required. So there has to be, the buck stops with me in the end because I'm the one that has to define the treatment. So I have to quantify that it really has to be done. After we're done, if you first work with me and we've done 4 or 5 chartings, we're going to be exactly the same. And I don't expect to have to check what you're doing. So, for instance, myself, I really don't check for calculus when I come in for a hygiene visit. My expectation is it's gone. What I want you to do is tell me you've had problems reaching a certain area. Doctor, can you help me because I'm concerned I haven't reached it or I didn't get it all. What I don't want to see on an X-ray is the last time they were in, they had a hygiene visit, and now I'm seeing calculus that was there from the visit before.
Yep.
So now I've got to question your technique because I want to see the X-rays up on the viewer when I come in, and I want to go back a visit and forward a visit so I have the information to assess what's happening subgingivally. And the challenge from a dentist that hygienists have to appreciate, I talked about I've got 4 hygienists to take care of at the same time, and my patient, and I'm probably running the practice.
Yeah.
So my time's valuable, and we have to learn to communicate so it's used properly, that I don't spend too much time or not enough time, and that you do the work of communicating and diagnosing, and I'm more confirming. And it should be yes, yes.
Right.
But there are coachable and teachable things that come up that I have to work with. And you know what? The patients love that, because I like to talk over the patient because they think we're really smart and we're really intelligent because we're talking about this. It's not whispering behind them.
Yeah.
You have a debate over how to treat, and then you look, we've been talking about the best way of doing this, and for this reason, I think I'd like to do this for you.
Yeah.
And the patient love it.
Yeah, that's so good.
So I don't see it adversarial. I see it very, very focused and very positive for the patient.
Nice.
Gosh, I wish all doctors would think that way.
I know. But this is why we have the ones that we have on
to
here.
understand why they're doing what they're doing.
Yeah, again, because the hygienists need to understand
sure.
that end of it as well, for sure. So we really do appreciate that you came on and spoke to us about this, and that you are Dr. Hygiene, and you are empowering hygienists and helping us do better care, make healthier patients.
I think the opportunity for hygiene has never looked brighter. I mean that so sincerely. But you have to have passion, and you have to care, and that has to come through, because it's that will motivate your patients and get them healthy, not the procedures you do. And if you can develop that using some of the things we've talked about today and focus on this oral systemic connection, you're going to have a great time practicing. You're not going to be cleaners. You're going to be educators, motivators, and people that get people well. So thanks for the opportunity to talk.
Yes.
Look up the Oravital website.
Yes. We want to know all the content. How do we get in touch with you, or the website, or find the product?
If you want to contact me personally, it's Dr. Jim, Jim, Hyland, Hyland, at Oravital, ORAVITAL.com. My phone number, 416-930-0310. Welcome your information, welcome your requests, and I'll try and respond to all of them.
You're only the third person out of 60 plus
something
episodes,
that gives us
almost 70
number.
episodes that gave their phone number out. So we appreciate that.
Well,
we do.
I'm on a mission to change how hygiene is practiced in the world. And I believe our system will do it. And we mentioned our results are guaranteed. So I'm putting my neck out there, and I better be able to deliver. Thank you all.
Thank you,
Have a great day, and enjoy practicing.
Thank you. Listeners, I want to tell you a story I found on the web, which makes this Scaling the Web with Andrew. All right. This week, Scaling the Web. I have a website. It's called deardoctor.tv. And basically the idea of this is, when you were working in the perio office, did you guys have a TV in your waiting room?
No. We had one in the room.
See, and I feel like we're missing an opportunity to kind of lay the ground floor.
You are...
What?
Speak it to the choir. I actually was trying to, and then of course this always gets put on the back burner, but I was trying to do research to show that that is an opportunity that we are missing to educate and have patients. Because you can go through this, of course, in your Scaling the Web, but for me, I would love for for the patient to initiate that conversation. Even if they come in there and say, I actually have a blog somewhere on this. If they come in there saying, you never told me I was supposed to brush like this, and I've said it 47,000 times, and I want to run my head into a wall, because how many more ways can I say it? But I would just be happy that, because they are not in that chair and they're able to take it in better, I think, in a very non-threatening environment like a waiting room or reception area. I think we're missing a huge opportunity I have a blog somewhere about this, actually.
Well, if you find the link, we'll put it on the show
Sorry.
notes. Anyways, so I'm going to play this short video as an introduction. I'm going to do my best. Hopefully we don't get a lot of feedback. So please hold as I hook this up.
Put your reception area to work for your dental practice. Transform it into a lively patient education center that not only explains your treatment recommendations, but also makes dentistry come to life for your guests. Introducing Dear Doctor TV, an innovative new approach to delivering the finest patient education and entertainment available. Dear Doctor TV features segments endorsed by the profession's leading organizations and exclusive interviews with celebrities who understand the true value of dental care, as well as fun facts, dental trivia, and so much more. Best of all, the content your patients watch on Dear Doctor TV is tailored to your individual office and your goals for practice growth. Here's how it works. Once you sign up, you will select content related to the treatments and procedures offered in your practice. You will then receive a pre-programmed mini computer filled with the trusted, high-quality educational content for which Dear Doctor is known. Simply plug the device into your TV, and within minutes, your reception area will be transformed. Your internet connection will enable Dear Doctor to update your content frequently so that your patients and guests always have something new to watch and learn. Best of all, Dear Doctor TV decreases your patients' perceived wait times while helping them gain a better understanding of the services offered at your practice. They will have a deeper appreciation for the work you do and how it positively affects their lives. To get started, call Dear Doctor today.
And so, I mean, it's a video, so we're obviously missing a lot of the visual component of that. So I'll put the link in the show notes and you guys can check it out a little bit later, but it's pretty cool. I like the idea of it. No, they aren't sponsoring this podcast or paying us in any way to say all that, but I think it's pretty darn awesome.
I want to go work for them. I'm totally down with that. I want to film all those. I love that side of it. Well done, Andrew. Another scaling a web, and I like how you had somebody else do that for you because you're such a tired man right now.
And it just so happened to work out well.
Way to be
for me.
lazy, but look like you did work. Good job.
Thank you. I was clapping for myself earlier too, since you kind of missed that part. But
it's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
On to story time with Michelle. And I have my big old glass of wine here. It's from Klein Wineries. Lola, lay down. My puppy wants to be a part of it too. Do you see her all up in my face? Go lay down, baby love. I love you. You're the best
Lola,
in the world.
go lay down.
Go lay down. Mommy's working. She's like, you're always working, Mom. All right, so we're still continuing to read from the Communication Skills for Dental Health Care Providers. I think this one might be a little long, but I think it's actually really good info. So, again, I'm trying to figure out how to hold a mic and a book at the same time. So this chapter is called Preparing for Patient Communication and Why Preparation Matters. So 5 decades of research on source credibility indicates that the way a message is received, interpreted, and recalled is influenced by variables in 5 domains: source, message, channel, receiver, and destination. The source's task of crafting a message, selecting a channel, addressing a receiver, and accounting for features of the destination are complicated by the fact that the source of the messages is simultaneously a receiver of messages. Although many communication guides focus on individual expression, the challenge for dental professionals is to craft an appropriate message at the same time as they are receiving messages from the patient. So this is why I think that this chapter is pretty interesting, and I wanted to kind of touch on a lot of it instead of just little bits and pieces. So this is going to talk about the stereotypes of dentist, which I find really interesting, and I didn't even realize there were all these stereotypes. So stereotypes are pretty pervasive and often operate outside awareness. In the United States, stereotypical characteristics of dentists tend to be negative rather than positive. One reviewed a century of portrayals of dentists in film and concluded that dentists often still are portrayed in the movies in a comedic role or as incompetent, sadistic, immoral, disturbed, or corrupt. And that is so true, right?
Yeah.
And I think hygienists are perceived as something like super simple and pretty. Always like the hot hygienist that just went in for something simple, right?
It's totally me. Yeah.
The pretty part.
Yep.
Okay, they noted that previously underrepresented groups, either talking about women and racial minorities, are now cast in the role of dentists, but the negative stereotypes attaching to the role still persist. Film portrayals reflect and reinforce and shape attitudes of the audience. So in the absence of empirical research on popular stereotypes of dentists, popular films serve as a useful indicators of the characteristics attributed to dentists. I would like to also interject 2 instances. I often watch people floss on TV, and I'm like, who the hell taught them that? Like hands on either side of their ears, flossing their teeth. And I was like, people are going to see that and think that that's how they should floss. I want to come in and do consultant work for anybody that's doing any kind of dentistry in films and tell you, no, you're doing it wrong. Secondly, just today, I had an advisory board meeting for the college that I had to do before this, and I was getting ready. I had some background noise on, which was 30 Rock. Remember the show 30
I
Rock?
love 30 Rock, yeah.
Right? So good. So Tina Fey on that was like, ouch, my tooth hurts. I missed the dentist appointment today. And I was like, damn it, Tina. That just makes it seem like you can just miss any dental appointment. Like it doesn't matter. And people will catch on to that and think that that's how they should behave. So anyway, those are just 2 moments when I was like, oh yeah, this is so true. So 6 stereotypes hold particular relevance for patient-provider communication. 1, dentists are rejected physicians. 2, dentists are sadistic. 3, dentists are greedy. 4, dentists are lecherous. Is that right to say that?
Lecherous?
Lecherous? Lecherous?
Yeah.
Okay. 4, dentists are lecherous. 5, dentists are attractive. And 6, dentists are trustworthy. So I want to just touch quickly on a few of those. So dentists are rejected physicians. One persistent stereotype is that dentists go into dentistry because they were unable to enter and complete medical school. Dental students indicated that they sometimes must defend the decision to pursue dentistry to people who ask why they did not instead go to medical school. Medical students do not generally report explaining why they did not pursue dentistry. The stereotype of dentists are as rejected physicians likely derives from the cultural elevation of physicians in the U.S. and a poor understanding of education and training required of dentists. Same for hygienists, 100%. Other medical professionals, i.e. pharmacists, physician assistants, and nurses, likewise, are sometimes perceived as rejected physicians. This hierarchy of prestige may also persist in the research community. A running joke in The Hangover, great movie, I'd literally laugh at it every single time I watch it, involves the dentist's claim that he is a doctor. A physician in the film provides that stereotypical response. You said that several times last night, but really, you're just a dentist. Stu, you're just a dentist. Next, turning page. Okay. Dentists are sadistic. So pain is a motivator for a dental visit, and dental treatments are historically associated with pain. Olaf found that 20% to 30% of adults rated their previous visit to the dentist as moderately painful or worse, and 60% reported at least one very painful experience. Pain and the associated anxiety are sometimes unavoidable, but in the popular imagination, some dentists inflict pain intentionally, and some even enjoy doing so. The stereotype is so pervasive that audiences quickly perceive why dentists were selected to employ enhanced interrogation techniques in Marathon Man and The Spirit. Little Shop of Horrors dropped all pretense of pain as means to an end. The patient's torture was its own reward for that dentist. That was a hilarious movie, too. Dental professionals should remain aware of these stereotypes, acknowledge a patient's pain, and provide accurate information about the discomfort a procedure will entail. Patients expect some pain and are generally willing to endure it, but they react negatively when a dentist disregards it. Clinicians should avoid laughing and appear. I'm sorry, I have done that. Sorry. Clinicians should avoid laughing and appearing unconcerned when examining patients in pain or performing procedures that are causing pain. Providers who arrange a system for patients to signal when a pain becomes unbearable and then stop the procedure promptly are likely to be perceived as sadistic. I have probably laughed at people because they're just so dramatic about it. Okay, third, dentists are greedy. A third persistent stereotype is that dentists are motivated primarily by money. Several factors contribute to this stereotype. First, 38.2% of the U.S. population has no dental insurance, and patients may not be aware of the charges because they are more likely to pay out of pocket. Second, patients often may not perceive the multiple costs involved in running a dental practice, such as training, continuing education, and overhead and insurance. When patients mistakenly believe that they are paying only for the appointment time, they may believe they are paying too much. This is so true. Third, evidence suggests that dentists may be reluctant to serve lower-income patients, fostering the stereotype that dentists are interested mainly in the collectible fees from financially secure patients. All right, dentists are lecherous. Lecherous?
It's not
lecherous.
Lecherous. I might be wrong too. Listeners, let us know how you say it. That'd be great. Thanks.
That's not in my vernacular. All right. A fourth negative stereotype is dentists are prone to take sexual advantage of patients, including sexual harassment, abuse, and assault.
Those dentists.
One possible explanation. What did you say?
What? Nothing.
What?
Nothing. You'll hear on the replay.
Oh, Lord. One possible explanation for this stereotype is the publicity surrounding high-profile cases of dentists engaging in sexual misconduct with patients. What's that movie? The Horrible Bosses. Jennifer Aniston. That was hilarious.
Never watched it.
Another What?
Whoa.
Andrew, I can't even sometimes with you.
You know what? ADHA.
You never watched it.
We can watch it ADHA. No, I've never seen it. Why would I have seen it? How would I have seen that?
Oh, it's a good movie. There's 2 of them out. Horrible Bosses 2.
Oh.
So funny.
Okay.
And Jennifer Aniston is quite the deviant in that, which is probably why most men have watched it. Another explanation is the potential for misinterpretation for intrusive nonverbal behaviors, so proximity and touch required in dentistry. A third explanation is the potential for sexual hallucinations in patients emerging from anesthesia. Oh, this has happened a few times.
Wow.
On my end. A few times. It's actually happened quite a lot with in the special needs population that I went and rotated through. Oh, Lord. Whatever the reason for the stereotype, it appears to endure, as it was the plot point in 2011 film Horrible Bosses. Curiously, that in that movie, this sexually predatory dentist was a woman, although female dentists are rarely accused of sexual misconduct. Finally, providers should announce that what they are doing and why, guiding the interpretation so that the patient will be less likely to attribute proximity and touch to deviant motives. Turning the page. I really feel like I'm like in a library.
You don't know what that's like.
All the young. Hey, dude, I loved a library. I'm a reader. All right. Dentists are attractive. I find this hilarious. Because I have often asked, where is our man candy? Where's our eye candy? Dentists can and should benefit from the attractiveness stereotype, but also must be careful to maintain professional boundaries. Dentists' teeth and breath advertise the quality of their work, so they should be in excellent condition. Dental professionals should encourage mutual trust and liking in the patient relationship, but must also sensitize themselves to indicators of danger. Dangerous dentist behaviors behaviors include consistently treating patients of one sex differently than patients of the other sex, or treating one patient much differently than the others. Dangerous patient behaviors include inappropriate verbal disclosures, questions, touching, and gift giving. Man, I worked for one dentist. He needed to get it together. He was always kissing people. It's like, stop.
Like on the mouth?
Ugh. He occasionally did. Oh, God.
Oh.
But he was like an old school dentist, and those women ate that shit up. It was disgusting.
Like Richard Dawson from Family Feud back in the day? Isn't that who it was?
Yes. They're probably pretty much the same generation, too. Dentists are trustworthy. So seemingly incompatible with the negative stereotypes discussed is a positive stereotype that may compensate for all the negative associations. People trust dentists. In Gallup polls on the ethics and honesty of various professions, dentists consistently placed in the top 10. In the 2009 poll, 57% of respondents rated the honesty and ethical standards of dentists high or very high. This rating placed dentists sixth behind nurses, pharmacists, physicians, police officers, and engineers. The ranking is high but below the 62% rating achieved in 2006 and continues to decline. Interesting. Christensen attributed that trend to several factors relating primarily to dentists focused on financial concerns to the neglect of patients' needs. Okay, so that was it for the stereotypes, but there is one part that I did want to touch on too, and that was patients with dental anxiety and how to talk with them. So dental anxiety, an extensive research literature has developed around the causes and treatment of dental anxiety. Older patients and women are more likely to exhibit dental anxiety, which is often a consequence of negative experiences.
Say that one more time.
Let's see. Older patients and women are more likely to exhibit dental anxiety, which is often a consequence of negative experience. Got it? A 1996 study found more than 3/4 of the population reports direct negative dental experiences. 71% said painful, 23% said frightening, and 9% said embarrassing. Further, the relationship between dental anxiety and such experiences is strong. Patients can also develop anxiety vicariously through the experiences of others. So anxious patients or friends who had a painful procedure. A more recent study by Armfield found that previous negative dental experiences are weaker predictors of anxiety than our perceptions of uncontrollability, unpredictability, dangerousness, and disgustingness. Interesting, right?
Yep.
So there were, when you're talking about communication strategies with anxious patients, they identified 3 chair-side approaches effective to reducing dental anxiety. First, the progress of the appointment should be highly predictable for the patient. So they should kind of always know what's going to happen in that appointment. Second, the teaching of coping skills to anxious patients reduces their anxiety. Such skills can include thought stopping, deep breathing, meditating, and positive affirmations. Third, desensitization to stimuli is an effective way to reduce anxiety. So the European study ranked 67 stimuli by the degree of patient anxiety that they invoked. So that's things like the needle, the handpiece, cold air on the tooth. So just making sure that you are warning people and keeping those kind of things out of sight, or just at least preparing them when you can't, like cold air or the handpiece. Patient preferences. So a growing body of research documents patient preferences and patient perceptions of the ideal dentist. Despite broad agreement across various demographic categories, however, patients often differ from one another in their preferences for many attributes and behaviors. The following sections discuss communication relevant preferences that have emerged in the literature. So one of them being communicative and honest. So research reported strong preferences among Finnish patients for communicative and informative patients or dentists. Behaviors associated with this attribute, including telling patients why procedures are being done, asking if the patient has specific concerns, and encouraging patient questions and telling what procedures are involved in the treatment, which I think sometimes we do not always do. What's the smirk for?
Nothing. I don't know. It just seems so simple. Like, this seems like so duh.
It does, but sometimes we just get going in our own, like, little world, or we're running behind and we just need to get shit done. I've found myself doing that and having a lot less patience and applying these skills when I'm like, this should be simple. I don't need you. Like, I could do this in 20 minutes, but it's taking me an hour. You know, like getting kind of frustrated or running behind. I think those are the times that happens more often. Sensitive. A 1993 study found that sensitivity is considered by patients as the most important attribute when selecting a dental practice. Specifically, patients prefer providers who are responsive to their pain and willing to discuss and overcome their fears. So just show some sensitivity. Collaborative. A study of decision-making preferences found that most patients prefer collaboration between the patient and the provider, although patients perceive that they play a passive role. A minority of patients preferred a more passive role, citing their lack of knowledge, trust in their provider, and time constraints as reasons to place decisions in the provider's hands. For supportive, one study found that in addition to professional skills, patients believe that the ideal dentist should be friendly and able to put patients at ease. And then professional in appearance. Patients also report preferences regarding their provider's appearance. Actually, the strongest appearance-related preference related to the smell rather than the look or dress. Patients prefer that their providers not smell of smoke or perfume. They also prefer that their dentist not have bad breath. Our research confirms these preferences, and our patients also report liking their providers to have a nice appearance and clean clothes. So what's interesting is that I've read on some of the dental forums where dentists are posting is that their assistants are coming in smelling of smoke or trying to cover. And this, I think sometimes people get a little too sensitive about that occasionally. But I think that this is a good thing to approach the assistant with. Not that, I don't want you smoking. Just that research tells us that patients who smell smoke or too much perfume or even alcohol, for that matter, are not going to be as trustworthy of the practice. And that is a cause for concern. So that might be a really great way to approach it. And if some of you hygienists or maybe even assistants listening are kind of having to deal with that in the office, that might be a good talking point to bring up.
True. So, good job.
Yep.
I agree.
Thanks. I feel like you were super interactive. You're only half there right now. I understand that. So we don't have to stay on and talk about life. I think that's all for this episode. I think it was a really good one, though.
It was great. It was fantastic. I really enjoyed it. And I hope everyone has a great week.
Great week. Episode 72 in the books. Whoop, whoop. Bye, y'all. Thanks.